Something changed for me in 1997. I had a patient, I will call her Margaret, 71 years old, who came into my office not for herself, but asking about her husband. He had been having falls, 3 and 4 months. His doctor told the family it was just normal aging. His gait had become unsteady. His memory was slipping. He had become, as Margaret described him, someone quieter, slower, confused about things that had never confused him before. I asked her to bring his medication list to our next visit. There were 7 medications on that list. 2 of them I recognized immediately as drugs I would not have prescribed to a 71-year-old man. Not because those medications are inherently bad. In the right patient, at the right age, in the right circumstance, they work exactly as intended. But after 70, the body metabolizes and responds to certain drugs in ways that are fundamentally different from what those prescriptions assume. His kidneys were not clearing these compounds at the rate the dosing was written for. His brain had become far more sensitive to effects that younger tissue tolerates without difficulty. His doctor was a good physician, a genuinely conscientious prescriber. He simply was not thinking about the specific body that man was living in at 71, in 1997, on 7 medications simultaneously. Today I want to share 6 specific medications that I believe every adult over 70, and every adult child caring for a parent over 70, should know by name. These are not rare drugs. They are not unusual prescriptions. Several of them you could walk into a pharmacy right now and purchase without a prescription, without a conversation with anyone behind the counter. I'm going to rank them from least urgent to most urgent, from number 6, where the risk is real but manageable with awareness, all the way to number 1, which I believe represents the single most under-recognized medication danger facing older Americans today. This will take about 30 minutes, and the most critical information is in the second half. Before we begin, I want to plant 3 things in your mind. There is one medication on this list that surprised me more than any other in my final years of practice, something I had prescribed without significant concern for decades before the research finally caught up to what it was really doing. I will reveal which one at the halfway point. There is also a question I am going to answer before this video ends, one that I believe most physicians are afraid to answer honestly. Why does this keep happening? Why do medications with documented risks in older adults keep being prescribed without a word of warning? That answer changed how I practice medicine, and it deserves to be said plainly. And finally, before this video ends, I will give you 4 specific words you can say at your very next doctor's appointment. 4 words that will trigger a complete medication review most seniors never receive. If anything you hear today connects to a medication you or someone you love is taking, leave it in the comments. I read every one personally. Now let us go to number 6. Your back goes out on a Tuesday morning. It happens getting up from the chair after breakfast, or bending to pick up the newspaper from the porch. You feel it immediately, that sharp electric catch across the lower back that takes your breath. By afternoon, you are moving slowly. By evening, you cannot find a comfortable position. You call your doctor. They call in a prescription, muscle relaxant. You pick it up on the way home, take one that night, and sleep harder than you have in months. This is one of the most common medication experiences in adults over 70. Muscle spasms from back or neck strain are among the most frequent reasons older adults seek medical care. And the prescription that follows, most often cyclobenzaprine, sold under the brand name Flexeril, seems entirely reasonable. It works. The muscle quiets down, you sleep, you feel functional again. What most people are never told is this: that same pill is producing blood concentrations in your 71-year-old body that are approximately twice as high as those produced in a younger adult taking the identical dose. Not marginally higher, twice as high. This happens because of the liver's reduced metabolic capacity after 70. Cyclobenzaprine is broken down by an enzyme pathway in the liver that slows significantly with age. The drug lingers in the bloodstream far longer than it was designed to, reaching concentrations the therapeutic dose was never intended to produce. And at those elevated concentrations, the compound does something that most patients are never told about. Cyclobenzaprine is not simply a muscle relaxant. Chemically, it is structurally nearly identical to amitriptyline, a tricyclic antidepressant. That is not a coincidence or a curiosity. It means cyclobenzaprine carries the full anticholinergic profile of a tricyclic antidepressant. In your brain, anticholinergic drugs block the activity of acetylcholine, the primary neurotransmitter involved in memory, attention, and coordination. When acetylcholine is blocked at twice the intended concentration, in a brain that has already experienced decades of age-related neurotransmitter decline, the effects are not subtle. Think of acetylcholine as the chemical that keeps your memory running and your balance steady. Now imagine blocking it at double the dose while you are walking to the bathroom at 2 in the morning in the dark. This is the clinical picture I saw repeated throughout my career, and that the research now confirms in population-scale numbers. A retrospective case control study, published in the Annals of Pharmacotherapy in 2013 by Spence and colleagues at Kaiser Permanente, analyzed injury outcomes in 27,974 older adults aged 65 and above. The researchers found that cyclobenzaprine use was associated with a statistically significant 22% increased risk of injuries serious enough to require hospitalization or emergency department care, even after adjusting for every other risk factor they could identify. The injury risk was independent. It persisted when they controlled for other medications, other health conditions, and functional status. Think about what that means for you. If you wake at 2 a.m. having taken a muscle relaxant, your sense of whether you are impaired is unreliable. The drug tells your brain that your balance is fine. It does not feel like being sedated. It feels like sleep. And in that gap between what your brain perceives and what your body can actually do, a bathroom floor becomes dangerous. The biological pathway here is distinct from every other point in today's video. What cyclobenzaprine disrupts is not a cardiovascular pathway or a kidney pathway. It disrupts the cholinergic system, the brain's network for moment-to-moment attention, coordination, and short-term memory. In an aging brain, where acetylcholine activity has already declined naturally over decades, adding an anticholinergic drug at elevated concentrations does not simply cause drowsiness. It can precipitate acute delirium. It can produce confusion that family members mistake for a sudden worsening of dementia. It can trigger falls during activities the person believed they were performing safely, walking to the kitchen, turning to reach the stove, stepping down from a curb. What happens when this system fails is not dramatic and obvious. It is subtle. The person seems a little slower, a little more confused than usual. Their mouth is very dry. They have not needed to urinate in a long time. They are unsteady when they stand. These are the signs of anticholinergic excess, and they are easy to dismiss as a bad day, a poor night's sleep, or just getting older. That is exactly what makes them dangerous. The specific mistake I saw consistently with this medication involves duration. Cyclobenzaprine is FDA approved for use for no more than 2 to 3 weeks. The evidence for its effectiveness beyond that window is essentially absent. There is no trial demonstrating it works longer than 14 days. None. But prescriptions for muscle relaxants in older adults routinely become long-term, and in some cases, permanent. I reviewed medication lists in my last years of practice, where a patient had been taking cyclobenzaprine daily for 18 months for a back spasm that the drug had no documented ability to treat beyond the first 2 weeks. If you are currently taking cyclobenzaprine, do not stop it abruptly. While cyclobenzaprine does not carry the severe withdrawal risks of some other sedating medications, abrupt discontinuation after prolonged use can cause rebound effects. This is a conversation to have with your physician. What you bring to that appointment is a direct question. How long was this prescription intended for, and what is the plan to discontinue it? For back muscle pain in adults over 70, heat application, gentle walking, and short-term acetaminophen at appropriate doses provide genuine relief without anticholinergic risk. Physical therapy, assessed over 2 to 4 weeks, consistently outperforms muscle relaxants for long-term outcomes and carries no pharmacological burden in older adults. One additional benefit of addressing this with your doctor: when cyclobenzaprine is removed from the medication list, patients frequently report improvements in mental clarity within days. What was mistaken for early memory decline was, in some cases, medication. That is something a family can get back. I want you to hold one thought as we move from number 6 to number 5. What we just discussed, double drug concentration, anticholinergic burden, cognitive fog mistaken for aging, is happening with one drug taken short-term for a common, manageable condition. Now consider what happens with antibiotics, a drug class that most adults over 70 take with complete confidence because it was prescribed by a physician for a urinary tract infection or a chest infection, and they have taken it before without incident. Number 5 may surprise you, because the damage it causes does not begin while you are being treated. It begins after you leave, when you believe you are fully recovered, and it can last for months. If you found what I just shared about muscle relaxants genuinely useful, and you did not know it before today, there is something I want to say to you directly. You probably found this video by searching for something specific, and may not have come across this video series before. I publish new health information made for people your age every single week, before most of it reaches your doctor's desk. To make sure you see it, press the subscribe button just below this video. It takes 1 second and there is no cost. If you do not subscribe, the next video, which covers 5 more situations where common medications harm older adults, may simply never reach you. You get a urinary tract infection, or a sinus infection your body is not clearing, or a respiratory illness your doctor is concerned about. The most common prescription that follows, for millions of older Americans each year, is a fluoroquinolone antibiotic, ciprofloxacin, levofloxacin. You know these by the names Cipro and Levaquin. You take the full course, 7 to 10 days. The infection clears, you feel better, you return to your life. 2 to 3 weeks later, you notice something, your heel, your shoulder, a tendon somewhere in your body that you do not remember straining. One that simply aches with a dull, persistent discomfort that was not there before. You assume it is arthritis, you assume it is aging, you assume it will pass. In a meaningful percentage of adults over 60, it does not pass. And the reason it started has nothing to do with arthritis or aging. It has to do with a class of antibiotics that the FDA placed a black box warning on in 2008, the most serious category of warning it can issue, and that millions of older adults continue to receive without that warning ever being communicated to them in plain language. Fluoroquinolones work by inhibiting bacterial DNA replication. They are genuinely effective antibiotics, but they have an off-target effect that is now well established in the clinical literature. They are directly toxic to connective tissue. Specifically, they accelerate the breakdown of tendon matrix through mechanisms involving metalloprotease enzymes. Enzymes that, when activated by fluoroquinolone compounds, degrade the structural protein scaffolding inside tendons. The Achilles tendon, the rotator cuff, the quadriceps. In a younger body, this degradation is largely reversible over time. In a body over 65, where connective tissue repairs more slowly and tendon blood supply has diminished with age, the damage can become structural and lasting. A nested case control study published in JAMA Neurology in 2019 by Morales and colleagues used a large primary care population database to analyze the association between fluoroquinolone use and peripheral neuropathy, nerve damage, in adults prescribed these antibiotics. They found that fluoroquinolone use was associated with a 47% increased relative incidence of peripheral neuropathy compared with patients prescribed non-fluoroquinolone antibiotics. And critically, the highest risk occurred in men over 60. The harm was concentrated in the exact age group that receives these prescriptions most frequently for routine infections. Think about what that means for you. The tingling in your feet that you notice 3 weeks after finishing a course of antibiotics. The numbness in the toes that your doctor attributes to diabetic changes or poor circulation may in some cases be a direct pharmacological injury from the antibiotic itself. And because the connection to the antibiotic is not recognized, the antibiotic is often prescribed again for the next infection, compounding the damage layer by layer. The biological mechanism here is entirely different from what we discussed with muscle relaxants. This is not a neurotransmitter pathway. Fluoroquinolones interfere with mitochondrial function in connective tissue cells, tendons, peripheral nerves, and cartilage. The mitochondria are the energy-producing structures inside every cell in your body. They are particularly vulnerable to fluoroquinolone toxicity because of a structural similarity between mitochondrial DNA replication and bacterial DNA replication. The same mechanism that kills the bacteria also disrupts energy production in human tissue. In aging cells, where mitochondrial efficiency has already declined, this disruption is amplified rather than buffered. What happens when this system breaks down is a picture most older adults never connect to a prescription they finished weeks earlier. Your tendons become painful without apparent cause. they become fragile. The Achilles tendon, the thickest, most load-bearing tendon in the body, becomes vulnerable to rupture at forces that would not have injured it before. Research in archives of internal medicine found that 2 to 6% of Achilles tendon ruptures in adults over 60 can be directly attributed to fluoroquinolone use. In a population of tens of millions of older adults receiving these prescriptions annually, that percentage represents a substantial number of real human injuries, surgeries, months of immobilization, permanent loss of function. The most common and dangerous mistake with fluoroquinolones is assuming that risk ends when the prescription ends. The tendon damage can appear up to 60 days after the last dose. The neuropathy can develop weeks after the course is complete. The prescription is gone from your cabinet, the infection has cleared, and your body is still processing the consequences. This delayed presentation is precisely why the connection is missed. The physician is not seeing the antibiotic and the tendon pain in the same visit. If you are ever prescribed a fluoroquinolone for a urinary tract infection or a respiratory infection, there is one specific question I want you to ask before you fill it. Is there an alternative antibiotic that would be clinically appropriate for this infection? For many uncomplicated urinary tract infections in older adults, trimethoprim sulfamethoxazole or nitrofurantoin, with appropriate attention to kidney function, may be suitable alternatives without the connective tissue profile. For respiratory infections, amoxicillin clavulanate, or azithromycin may be options, depending on the suspected organism. This conversation is worth having before you begin the prescription, not after you notice the tendon pain. There is also a specific combination that dramatically increases the risk. If you are taking corticosteroids, prednisone, methylprednisolone, or any similar anti-inflammatory steroid, at the same time as a fluoroquinolone, the risk of tendon rupture increases by a factor of several times over the antibiotic's baseline risk. This combination should be explicitly discussed with every older adult who is prescribed it. One further benefit of recognizing this: peripheral neuropathy that is identified early as potentially medication-related has a chance of improvement once the causative drug is discontinued. Neuropathy that is attributed entirely to diabetes or aging is simply managed, not investigated for reversible causes. Reversibility matters. It means some of what has been accepted as permanent may not be. We have now discussed medications acting through the cholinergic system and the mitochondrial connective tissue system. The next medication works through a third pathway entirely. It has nothing to do with the brain or tendons. It has to do with how the body maintains blood sugar at the most vulnerable moments of the day, and what happens when that system is disrupted in an aging body that has quietly lost several of its natural defense mechanisms. Number 4 carries a risk of harm that can occur within hours of a single dose, that can cause loss of consciousness without warning, and that is more than 3 times more likely to affect you now that you are over 65 than it was a decade ago. Take a moment with what you have heard so far. You now know that a common back pain medication doubles its concentration in an aging body, quietly impairing the brain chemistry that keeps you upright, and that a widely prescribed antibiotic carries a documented risk of tendon and nerve damage that appears weeks after the prescription ends. That is genuinely important information most adults over 70 have never received. Here is something that surprises almost every patient I have shared it with. The first symptoms of fluoroquinolone tendon damage are frequently indistinguishable from arthritis flares. The same aching, the same stiffness, the same gradual onset. This means fluoroquinolone-related tendon injury is almost certainly far more common than reported statistics suggest. The connection simply is not being made in the exam room. Something is coming in point number 4 that I believe may be the most practically important thing in today's video for anyone managing diabetes. It involves a medication that has been on the Beers criteria, the American Geriatrics Society's list of drugs to avoid in adults over 65, since 2012. What makes it uniquely dangerous is not just what it does, but something it fails to do when your blood sugar falls to a level that should make any medication stop working. Point 4 will explain exactly what I mean. It is 7 in the morning. You took your diabetes medication with dinner the night before. You rise, move toward the kitchen for coffee, and something does not feel right. A lightheadedness deeper than the usual morning adjustment to standing. A sense that your thoughts are not connecting cleanly. Your hands feel slightly trembling. You sit down, you eat something quickly, and within 15 minutes you feel better. Maybe you do not fully recognize what just happened. What you experienced is a hypoglycemic episode, low blood sugar. And if you are taking glyburide, sold under names including DiaBeta and Micronase, for type 2 diabetes, that experience is not incidental. It is a predictable pharmacological event that is occurring because of a specific property of glyburide that makes it categorically more dangerous for adults over 70 than for younger patients. Glyburide belongs to a class of diabetes medications called sulfonylureas. Sulfonylureas work by stimulating the pancreas to release insulin. The insulin then lowers blood sugar. Glyburide has been used for type 2 diabetes since the 1980s and has genuinely helped millions of people manage their glucose. But there is a fundamental problem with glyburide specifically that the newer alternatives do not share. It does not respond to falling blood sugar levels. Most modern diabetes medications are glucose sensitive. When your blood sugar drops, they stop working. Glyburide does not do this. It continues to stimulate insulin release, regardless of how low your blood sugar falls. For a 45-year-old with intact kidney function, robust liver metabolism, and a strong counter-regulatory hormone response, the system your body uses to naturally raise blood sugar when it drops too far, this property is manageable. For a 73-year-old whose kidney function has declined by 30 to 40%, whose liver metabolizes the drug more slowly, and whose counter-regulatory response has weakened with age, it is a formula for dangerously prolonged low blood sugar. A nested case control study published in Pharmacotherapy in 2012 by Dusenberry and colleagues at the University of Pittsburgh examined hypoglycemia outcomes in hospitalized adults treated with various sulfonylureas. They found that 22% of patients receiving glyburide experienced at least one hypoglycemic episode, and that being age 65 or older carried an odds ratio of 3.07 for developing hypoglycemia while on a sulfonylurea. Adults over 65 were more than 3 times as likely to suffer a dangerous blood sugar drop as younger patients receiving the same drug. Think about what that means for you. 3 times more likely, not marginally elevated, 3 times. The biological mechanism here is distinct from everything we have discussed. This is a metabolic pathway. Glyburide has active metabolites, breakdown products of the drug that retain pharmacological activity. In a body with declining kidney function, those active metabolites are not cleared efficiently. They accumulate. They continue stimulating insulin release long after the intended duration of action has passed. The result is a kind of pharmacological oversteer. The drug keeps driving blood sugar down past the target, into ranges that impair brain function. What happens when blood sugar falls below the safe threshold in an older adult is more serious than in a younger person for 2 reasons. First, the counter-regulatory response, the release of glucagon and adrenaline that normally signals the body to correct, is blunted in older adults. The biological alarm system is quieter. Second, the symptoms of hypoglycemia in older adults are frequently different from the classic signs younger patients experience. Young patients typically sweat, feel shaky, and recognize that something is wrong. Older adults are more likely to experience confusion, dizziness, or sudden weakness, symptoms easily attributed to a dozen other causes. A family member sees an older parent suddenly confused in the morning and may think stroke, may think dementia, may not think blood sugar at all. This misattribution matters enormously, because while the family is trying to determine what happened, the blood sugar continues to fall. And glyburide-induced hypoglycemia can persist for hours, sometimes requiring intravenous glucose in an emergency room to correct, because the drug continues stimulating insulin after the oral glucose is consumed. The most common mistake I saw with glyburide was continuity without reassessment. A patient was started on it at 58, when their kidneys were functioning normally. By 72, their kidney function had declined significantly, a change any standard annual blood panel would capture if someone was looking for it. But the glyburide prescription had simply renewed year after year, unchanged, with no recalculation for altered clearance. The drug that was appropriate in 1999 had become inappropriate and potentially dangerous by 2013. The prescription never changed. The body did. If you are currently taking glyburide, please do not stop it on your own. Making any change to a diabetes medication without medical supervision can cause blood sugar to rise dangerously. What I am asking is for a specific, informed conversation with your physician. Ask whether your kidney function has been measured recently, and whether that current kidney function is still appropriate for glyburide use. Ask whether glipizide, a different sulfonylurea with a substantially shorter duration of action and no active metabolites, might be a safer alternative for your current situation. The American Geriatrics Society lists glyburide specifically on the Beers criteria as a medication to avoid in adults over 65. Glipizide and glimepiride are not on that list. One critical additional warning: several commonly prescribed antibiotics, including ciprofloxacin, which we discussed in point 5, interact with glyburide to amplify its blood sugar lowering effect. If you are ever prescribed an antibiotic while taking glyburide, tell the prescribing physician about the glyburide specifically, and ask whether the antibiotic chosen is one that interacts with sulfonylureas. This interaction has been documented in Medicare claims data from tens of thousands of patients. It is not theoretical. One unexpected benefit of addressing this with your physician: the medications that have replaced glyburide in modern diabetes management are not only safer for kidney function, several have documented cardiovascular protective benefits as well. Whether they are appropriate for your specific situation requires a clinical conversation, but that conversation is worth initiating with the knowledge that you now have. We have covered 3 entirely different biological pathways: cholinergic, mitochondrial, and metabolic. What comes next surprised me more than anything else in this research. I said at the start that one medication on this list surprised me in my final years of practice. One I had prescribed without significant concern for decades before the evidence changed my thinking entirely. You are about to find out which one. You have stayed with me through 3 of our 6 medications, and I want to say something to you directly. What you are doing right now, sitting with this information, connecting it to your own life, is not passive. It is one of the most meaningful things a person can do for their health. I want to acknowledge that. What we have covered so far: cyclobenzaprine, the muscle relaxant that produces double the blood concentration in an aging body, blocking the brain chemistry you need for balance and memory, increasing the risk of falls at night by 22% in adults over 65. The fluoroquinolone antibiotics, Cipro and Levaquin, which carry an FDA black box warning most patients never see, damaging tendons and peripheral nerves through a mitochondrial pathway that unfolds weeks after the prescription is finished. And glyburide, the decades-old diabetes medication that continues stimulating insulin release even as blood sugar falls dangerously low, making adults over 65 more than 3 times as likely to suffer a serious hypoglycemic episode as younger patients on the same dose. Now, here is the answer I promised you at the very beginning of this video. The medication that surprised me most in my final years of practice was not the muscle relaxant, and it was not the antibiotic. It was what is coming in point number 3, a category of medication that many physicians, including me, considered among the safest modern prescriptions available for older adults. What the research eventually showed about its effect on a specific electrolyte in elderly patients changed my entire approach to prescribing it. The single most surprising finding still ahead involves a medication with an FDA black box warning that the majority of patients currently taking it have never been shown. What is coming in point number 1 involves a 60 to 70% increase in mortality risk. Stay with me. You deserve to hear the whole picture. If this information is already helping you think differently about your own medication list, press the thumbs up button below. It helps you save this video so you can come back to it easily. Before we go to the next 3 medications, I want to say something personally. If you have watched this far, you are the kind of person who genuinely cares about your health and your independence. I do not want you to miss what is coming next week, because it directly affects anyone over 70 taking blood pressure medication. I am covering what happens to common antihypertensives when kidney function declines, and a specific combination that significantly increases stroke risk in older adults. To make sure you see it, press subscribe just below this video. There is no cost. One press is all it takes. Now I need to talk about something that was genuinely difficult for me, personally, as a physician. For many years during my practice, if a patient over 70 came to me with real clinical depression, the kind that flattens daily life and removes the will to engage with the world. I felt confident prescribing a selective serotonin reuptake inhibitor, an SSRI, sertraline, escitalopram, paroxetine. These are sold under names you will recognize: Zoloft, Lexapro, Paxil. I was not wrong to consider them. Depression in older adults is undertreated and genuinely dangerous. It accelerates cognitive decline, disrupts sleep architecture, impairs immune function, and increases mortality in people already managing multiple health challenges. The decision to treat depression is often correct. But here is what I was not telling my patients clearly enough. What the literature eventually showed me, and what I want to tell you now with complete honesty: SSRIs, specifically in adults over 65, carry a risk of a dangerous electrolyte abnormality that most patients are never warned about. That abnormality is hyponatremia, critically low sodium in the blood. And in older adults, it can happen faster, at a lower threshold, and with more serious consequences than in any other population. Sodium is not simply a component of table salt. In your body, sodium is the electrolyte that governs water distribution between your cells and the fluids surrounding them. It maintains the electrical gradient that makes nerve signaling possible. When sodium falls below normal levels, brain cells begin to swell. Mildly low sodium causes headache, confusion, and unsteadiness. Moderately low sodium causes disorientation, falls, and seizures. Severely low sodium can cause coma and death. SSRIs cause sodium to fall through a specific mechanism. They stimulate excess release of antidiuretic hormone, ADH, which tells the kidneys to retain more water than the body needs. When excess water accumulates in the bloodstream, the concentration of sodium falls. This condition is called the syndrome of inappropriate antidiuretic hormone secretion, or SIADH. It is a known, documented, pharmacological effect of this drug class. It is not rare. It is not anecdotal. It is a mechanism built into how these drugs work. A population-based cohort study of older adults in Ontario, Canada, using linked health databases covering more than 138,000 participants across 2 matched groups, was published in the American Journal of Kidney Diseases in 2016. Researchers examined the risk of hospitalization with hyponatremia in older adults prescribed one of 9 second-generation antidepressants, including SSRIs, compared with matched adults not receiving these medications. They found that initiating treatment was associated with approximately a 5-fold increase in the 30-day risk of hospitalization for hyponatremia compared with matched non-users. Think about what that means for you. Within 30 days of starting one of these medications, the 30 days when a physician and patient most need to be watching carefully, the risk of hospitalization for dangerous low sodium is 5 times higher than in comparable adults who are not on the drug. What makes this particularly critical for adults over 65 or 70 is the compounding effect of diuretics. Many older adults take a diuretic for blood pressure or heart failure: hydrochlorothiazide, furosemide, chlorthalidone. These medications also tend to lower sodium. When a thiazide diuretic and an SSRI are combined in an older adult, 2 separate mechanisms for lowering sodium act simultaneously. A case control study in a Dutch clinical population found that the combination of SSRIs and diuretics in adults over 65 carried an odds ratio exceeding 13 for developing dangerous hyponatremia, more than 13 times the baseline risk of either drug alone. What does dangerous hyponatremia look like in practice? A 69-year-old woman who started sertraline 6 weeks ago. She seems more confused lately. She fell in the kitchen last Tuesday. She has been complaining of a persistent headache. Her family thinks the medication is not working. Maybe the depression is worsening. Maybe something else is going wrong. Her doctor, if not specifically checking sodium levels, may increase the antidepressant dose. The underlying problem, sodium depleted to a level that is affecting brain function, is never identified. The medication continues. The sodium falls further. The tragedy is not that SSRIs exist. For the right patient, with careful monitoring, they provide meaningful relief from a condition that is genuinely harmful and undertreated in older adults. The tragedy is the monitoring gap. Sodium levels in older adults starting SSRIs should be checked at 1 week and again at 4 to 6 weeks. particularly in anyone also taking a diuretic. This is not an exotic recommendation. It is straightforward clinical care. It is simply not happening consistently across practices. The most common mistake with this drug class is the word mild. Physicians choose SSRIs for elderly patients because they are described as mild compared to older antidepressants. Patients accept them without hesitation because mild sounds like low risk. But mild in this context means mild compared to the side effect profile of tricyclics in younger adults. It does not mean low risk in a 72-year-old woman whose sodium is already at the lower edge of normal and who takes a diuretic for her blood pressure every morning. If you or someone you love takes an SSRI and also takes a diuretic, here is the specific step I want you to take. At your next doctor's visit, ask this question: has my sodium level been checked within the last 6 weeks? A serum sodium measurement is a routine, inexpensive blood test. If it has not been checked since the antidepressant was started, ask for it now. For anyone on an SSRI who is not taking a diuretic, the risk is lower, but not absent. Standard monitoring still applies. Watch for confusion, unusual headache, nausea, or unexpected unsteadiness in the early weeks, and report these symptoms promptly rather than waiting for a scheduled appointment. One critical caution: if you are currently taking an SSRI for depression, do not stop it without medical guidance. Antidepressants must be tapered, not stopped abruptly. Abrupt discontinuation can trigger a withdrawal syndrome including dizziness, pronounced anxiety, electrical shock sensations, and worsening depression. This is a supervised process. We have now covered 4 distinct biological pathways: cholinergic, mitochondrial, metabolic, and the sodium-water balance governed by ADH in the kidney. 4 entirely different presentations of harm. And in every case, the harm occurs not because the medication is defective, but because it was designed for a body that processes it differently than the one you are living in at 70. What comes next requires your full attention. It involves a medication that millions of older adults take every day, whose therapeutic window is so narrow that the normal, expected decline of kidney function with age can push the drug from safe to toxic, with no change in the prescription at all. Before we go to number 2, I want to ask you something directly. Have you, or has someone in your family, ever been told by a doctor that confusion, a fall, or unexpected symptoms were simply aging, only to discover later that a medication may have been involved? Leave your answer in the comments below. I read every comment personally every week, and your experience may help someone else recognize what happened to them. Think about the ground we have covered together: muscle relaxant toxicity, antibiotic tendon and nerve damage, blood sugar collapse from a diabetes drug that does not know when to stop, sodium depletion from a medication most people consider gentle and modern. 4 entirely different biological systems, 4 entirely different presentations, and in every case, the harm was not written on the label in language a patient over 70 could act on. Here is something that surprises most people when they first hear it. Digoxin, the medication coming in point number 2, was originally derived from the foxglove plant, which European physicians first documented medicinally in the 1780s. It is one of the oldest cardiac medications in continuous clinical use, and it remains, today, one of the medications most likely to cause serious, unrecognized toxicity in adults over 80. Not because the drug has changed, because the kidney that must clear it has. Point number 2 involves a drug whose therapeutic level and toxic level are separated by a margin so narrow that normal, expected aging of the kidney, happening silently, without symptoms, in virtually every human body, can move a patient from the beneficial side of that line to the toxic side, with no change whatsoever in the prescription. Let me tell you about something that happened during a hospital consultation in my later career that I have never been fully able to put out of my mind. An 82-year-old woman was admitted after a fall with altered mental status. A neighbor had found her on the kitchen floor that morning, confused, unable to explain what had happened. Her blood pressure was low. Her heart rate was dangerously slow, 38 beats per minute. She had not been eating well for several days. She was on 8 medications. One of them was digoxin, which she had been taking for heart failure and atrial fibrillation for 9 years, at a dose of 0.25 milligrams daily. Her kidney function, when we measured it that morning, was significantly impaired. more so than records from 2 years prior would have suggested. She had not had a digoxin level checked in over 8 months. Her digoxin level came back toxic. The dose that was appropriate for her kidney function 9 years ago had become dangerous as her kidneys declined. The prescription never changed. Her kidneys did. Digoxin works by inhibiting a specific enzyme that regulates sodium and calcium balance inside heart muscle cells, which in turn strengthens each heartbeat and slows electrical conduction through the heart. For patients with heart failure and certain arrhythmias, particularly atrial fibrillation, it provides real and meaningful benefit. What makes it uniquely dangerous for older adults is the property known as narrow therapeutic window. The dose that provides benefit and the dose that causes toxicity are separated by an extremely small margin. For most medications, a large gap exists between a therapeutic dose and a toxic one. For digoxin, that gap is narrow enough that the ordinary, expected decline in kidney filtering capacity that occurs in virtually every human being after 70, roughly 10% per decade, can push a patient from the safe side of that line to the dangerous side with no change in the prescription. A single-center analysis published in the American Journal of Medicine, covering patients from 2000 through 2019, identified 727 adults who presented with signs of digoxin toxicity. The in-hospital mortality rate in those cases was 12.7%. The one-year mortality rate was 42.7%. Nearly half of the patients who experienced a significant episode of digoxin toxicity did not survive to their first anniversary after that hospitalization. Think about what that means for you. If you are currently taking digoxin and your kidney function has not been assessed recently, and your digoxin serum level has not been checked within the past few months, no one currently has a reliable measurement of whether the dose you are taking is producing a blood concentration in the therapeutic range or the toxic range. The two are simply too close together to assume without measurement. What does digoxin toxicity look like before it becomes a cardiac emergency? This is critical to understand, because the early signs of chronic toxicity, the slow accumulation that occurs when kidneys cannot clear the drug quickly enough, are not dramatic. They are fatigue, nausea, loss of appetite, visual disturbances, a yellowing of vision or halos around lights, mild confusion. These symptoms are easy to attribute to heart failure worsening, to aging, to a bad few days. They are rarely attributed to the medication at these early stages. That is exactly what makes them dangerous. The biological pathway here is fundamentally different from the four preceding it. This is a cardiac conduction pathway. Digoxin's toxic accumulation directly slows the electrical system of the heart, the nodes and pathways that time each contraction. When the drug level rises above the therapeutic range, the heart rate becomes dangerously slow. The electrical system develops abnormal rhythms. In severe presentations, complete heart block or ventricular fibrillation can occur. What makes the aging body specifically vulnerable involves 3 changes acting together. First, kidney filtration rate declines at roughly 10% per decade after 40, meaning an 80-year-old has significantly reduced capacity to clear the drug compared with when they were first prescribed it at 70. Second, the aging heart becomes more electrically sensitive to digoxin's effects. The toxic threshold lowers with age, even when blood levels appear stable. Third, many older adults also take diuretics for heart failure, which can lower potassium and magnesium in the blood. Low potassium dramatically increases digoxin toxicity at any given serum level, meaning a diuretic dose change or a few days of reduced dietary intake can push a previously stable patient toward toxicity without any change in the digoxin prescription. The most critical mistake with digoxin in older adults is the assumption that stability equals safety. A patient who has tolerated the same dose for 6 years is not necessarily still safe. They may be approaching the toxic threshold gradually, as kidney function declines 1% per year, as potassium fluctuates with dietary changes and diuretic use, as the aging heart's sensitivity shifts. The question is not whether they have tolerated the drug. It is whether the level is being measured regularly enough to detect when tolerance has ended. If you are currently taking digoxin, bring these 3 questions to your next appointment. First, when was my kidney function last measured? If it has been more than 6 months, ask for an updated creatinine and estimated glomerular filtration rate. Second, When was my digoxin level last checked? Guidelines suggest at least annually in stable patients, and within 1 to 2 months of any significant health change. Third, has my potassium been checked recently? If you are also taking a diuretic, this question is particularly important. If any of these questions reveals a gap, kidney function not measured in over a year, digoxin level not checked in 6 months or more, that is the information to bring directly to your physician, not as an accusation, as a patient who knows enough to ask. One final clinical note. In recent years, cardiologists have moved toward targeting lower digoxin serum levels for heart failure, 0.5 to 0.9 nanograms per milliliter, rather than the higher levels that were historically considered therapeutic. If your physician is targeting a higher range, ask specifically whether a lower target concentration is now recommended for your age and current kidney function. What comes next is the single item on this countdown that I believe carries the most serious and least recognized risk for adults over 70. It involves a medication that was the subject of an FDA black box warning, issued specifically for elderly patients, and that continues to be given to millions of older adults every night under circumstances far removed from what that warning was designed to address. Number 1 involves a 60 to 70% increase in the risk of death, and most patients receiving it have never been told. You are almost at the most important part of this entire video, and you have watched long enough that I know something real about you. You take your health seriously. That is not a small thing. If you have not yet subscribed, I want to ask you directly, please press subscribe below. You have already shown, by staying this far, that you care about your independence. Subscribing is simply the next natural step. This is the one I want you to remember. This is the one I want you to tell someone about after this video ends. If you or someone you love lives in a nursing home, assisted living, or memory care, or if you yourself take a medication for sleep, anxiety, or behavioral symptoms that was suggested as something to help calm things down or take the edge off at night, I need you to hear what I am about to say with complete attention. Atypical antipsychotic medications, quetiapine sold as Seroquel, olanzapine sold as Zyprexa, risperidone sold as Risperdal, aripiprazole sold as Abilify, carry an FDA black box warning, issued specifically, explicitly, and formally for elderly patients with dementia. The warning states that these drugs are associated with an increased risk of death in this population, and that they are not approved for the treatment of behavioral symptoms of dementia. They are prescribed for this purpose millions of times per year. But the issue I want to address today goes beyond dementia. These same medications are being prescribed off-label to older adults for sleep, for anxiety, for agitation, for combativeness, for any behavioral description that is applied to someone over 70 who is distressed, confused, uncomfortable, or in pain they cannot clearly communicate. Seroquel, in particular, has become one of the most widely used off-label sleep aids in long-term care environments. A quarter tablet, half a tablet, just enough to keep someone quieter at night. There is no established safe dose for this use in this population. There is no long-term evidence that off-label antipsychotic use in older adults without a psychiatric diagnosis provides clinical benefit that outweighs its documented risks. There is extensive evidence that it causes harm. A rigorous clinical cohort study, the AMRAD study, published in BJ Psych Open in 2022, by Fury and colleagues, used linked electronic health record data following 1,692 patients with dementia from 2013 through 2017. Patients prescribed olanzapine showed a hazard ratio for death of 1.32 compared with matched controls not receiving antipsychotics. Patients prescribed risperidone showed a hazard ratio of 1.35. These patients were approximately 32 to 35% more likely to die during the follow-up period than comparable patients not prescribed these medications. Combined data from the FDA's formal review of 17 placebo-controlled trials found that death occurred in 4.5% of drug-treated patients, compared with 2.6% of placebo patients, a 1.6 to 1.7-fold increase in relative mortality. A 60 to 70% increase in the risk of dying, compared with patients who received no antipsychotic at all. Think about what that means in practice. If a memory care facility is using quetiapine or risperidone in its residents to manage behavioral symptoms or promote sleep, and many do, The medication that is supposed to keep those residents comfortable is associated with a substantially elevated probability that they will not survive the year. The biological pathway here involves multiple systems acting simultaneously, which is part of why the harm is so significant. Antipsychotics are deeply sedating, directly increasing fall risk. They affect cardiac electrical conduction, prolonging the QT interval, a change that increases the risk of a potentially fatal arrhythmia. They appear to be associated in elderly patients with elevated rates of aspiration pneumonia, possibly because deep sedation impairs the swallowing reflexes that protect the airway. And they carry significant anticholinergic properties, similar to what we discussed with cyclobenzaprine in point 6, further impairing the brain chemistry involved in memory and coordination at a time when those systems are already compromised. When all of these effects occur simultaneously, in a body already managing heart disease, declining kidney function, existing cognitive impairment, and multiple other medications, the outcome cannot be predicted from any single pathway. It is the sum of all of them at once. The most common and most disturbing pattern I observed with atypical antipsychotics in older adults involves the management of distress. When an older adult with dementia becomes agitated at night, wandering, calling out, resisting care, this is almost always a communication of an unmet need: pain, hunger, fear, disorientation, a urinary tract infection causing burning discomfort they cannot articulate. The correct clinical response is to identify and address the underlying cause. The faster, easier response is to prescribe a small dose of Seroquel and document that behavioral symptoms have been managed. This is not hypothetical. This is what happens in clinical environments under pressure, with insufficient staffing, without the time required for proper behavioral assessment. And the consequence, a 60 to 70% increased mortality risk, is paid by people who cannot advocate for themselves, whose families may not know what their loved one is being given, and whose deaths may be attributed to the natural progression of dementia, rather than to a medication that should never have been prescribed. If you are the family member or caregiver of an older adult in any care setting, ask specifically. Ask, what medications is my parent currently receiving for sleep or behavioral management? Has a physician reviewed and formally justified each one? If quetiapine, olanzapine, or risperidone appears on that list without a documented psychiatric diagnosis and specific justification, that conversation needs to happen with the prescribing physician. Now, if you are over 70 yourself and have been prescribed any of these medications for sleep or anxiety without a formal psychiatric diagnosis, please bring the bottle to your next appointment and ask your physician, is this medication FDA approved for the condition it is treating in me? And what is the plan for how long I will be on it? These medications do have appropriate uses in older adults with specific psychiatric conditions. Schizophrenia, bipolar disorder with psychosis. These are conditions for which antipsychotics can provide irreplaceable benefit, even in elderly patients. The concern raised here is not with those uses. It is with the widespread, casual, underdocumented use of these medications for sleep, for convenience, for any discomfort that a system finds easier to medicate than to address. For sleep difficulties in adults over 70, cognitive behavioral therapy for insomnia, CBTI, consistently outperforms every medication in long-term clinical trials, with no drug interactions, no dependency, and no cardiac or neurological side effects. Melatonin at low doses, specifically timed, is a reasonable short-term option for circadian disruption. Addressing pain, bladder urgency, and sleep apnea, common and underdiagnosed in this population, often resolves insomnia without any medication being necessary. The most vulnerable people you know deserve better than a drug that increases their chance of dying in order to make them quieter at night. Here's what I want you to do after this video ends. Not next week, this week. Step 1. Write down every medication you currently take, every single one. Prescriptions, over-the-counter, anything you take regularly. Include the name, the dose, and how long you have been taking it. This list is the most useful document you can bring to any medical appointment, and many older adults have never actually assembled it in one place. Step 2. For each medication, ask yourself honestly, when did a physician last review this? Not just refill it, but review it. Refilling is not reviewing. Reviewing means someone sat with you, looked at your current kidney function, considered whether the original reason you were prescribed it still applies, and made a conscious decision to continue. If that conversation has not happened in the past year, it is overdue. Step 3. For the specific medications we covered today. If you take cyclobenzaprine or any muscle relaxant, ask your doctor, how long is this intended for, and what is the plan to discontinue? If you are ever prescribed ciprofloxacin or levofloxacin for an infection, ask whether an alternative antibiotic is clinically appropriate before filling. If you take glyburide, ask whether your current kidney function is still appropriate for this specific drug, and whether glipizide is a suitable alternative. If you take an SSRI and also a diuretic, ask when your sodium was last measured, and if the answer is not recent, ask for it now. If you take digoxin, ask for your kidney function and your digoxin serum level. If you or a family member is on quetiapine, olanzapine, or risperidone without a formal psychiatric diagnosis, ask directly what that medication is treating and what the plan is for its duration. Step 4. Request a geriatric medication review. Use those exact words. Tell your physician, I would like a geriatric medication review evaluated against the American Geriatric Society Beers criteria. Your physician will recognize those words. The Beers criteria is publicly available at the American Geriatric Society website at no cost. Now for specific daily timing that matters. For digoxin, take it at the same time each morning, consistently relative to meals. Do not take it with high-fiber foods like bran cereals, which can bind the drug and reduce absorption significantly. For glyburide or any sulfonylurea, take it with your largest meal of the day, and never on a day when you plan to eat unusually little or skip a meal. That combination, sulfonylurea plus minimal food intake, is precisely when dangerous blood sugar drops occur most predictably. For midday, SSRIs taken at a consistent midday time tend to produce fewer sleep disturbances in older adults than evening dosing, and the first 4 to 6 weeks of SSRI use are the window of highest sodium risk. Any confusion, unusual headache, or unexpected unsteadiness during this period warrants a call to your physician the same day. For evenings and nights, if you take any sedating medication, practice this sequence every time you get up at night. Wake slowly. Sit on the edge of the bed for 30 seconds before standing. Turn on a light before you move. Falls in the night are responsible for a disproportionate number of the serious injuries I spent my career treating. Most of them are preventable with these small, consistent adjustments in how you move. For realistic expectations over the coming months, the medications discussed today do not produce sudden dramatic harm in everyone who takes them. What the research describes is elevated probability over time, the compounding of risk in a body that is less able to buffer pharmacological stressors than it was 20 years ago. Addressing these medications does not guarantee freedom from all harm, but it meaningfully reduces a specific, identifiable, and in many cases entirely preventable risk. 1 month from now, if you have had even one of these conversations with your physician, and one medication on your list has been reviewed with the full picture of your current kidney function and age in front of the prescribing doctor, you will have done something genuinely significant for your health and your independence. That is not a small thing. That is your life. In the last years of my practice, I began sitting with something I had not fully allowed myself to feel for most of my career. I had been a good physician. I cared about my patients. I stayed current. I attended conferences. I read the literature. And still, I had prescribed medications from the list you heard today to people who trusted me completely, at doses appropriate for their age at the time of prescribing, without building into my practice the consistent, scheduled reassessment that aging bodies quietly require. I was not negligent. I was not careless. I was practicing medicine in the system as it existed. 15-minute appointments, full panels, limited time for the kind of whole-person review that the complexity of aging genuinely demands. And I believe that is the honest answer to the question I promised you. Why does this keep happening? Not because physicians are bad, not because the system is evil, because the medical system was designed, largely, around acute care, around diagnosing and treating the thing directly in front of you today, not around the long, slow pharmacological accumulation that builds in a body that is 74, on 7 medications, with kidneys that have lost 1/3 of their filtering capacity since the first of those prescriptions was written. The patient in front of a physician for 15 minutes is a snapshot. A 70-year-old body on 7 medications is a story with chapters, and the chapter from 10 years ago may no longer be true. Here is what I want you to carry with you from today. This is the statement I would ask you to hold on to, and perhaps share with someone you love. The fact that a medication is still on your list does not mean it is still appropriate for the body you are living in now. I want you to sit with that for a moment, not with fear, with clarity. A prescription is written at a moment in time. Your body continues to change. The distance between those two facts is where a great deal of preventable harm quietly occurs. Not through negligence, not through carelessness, but because patients were never given the information they needed to ask for a reassessment, and because the system rarely prompted one. That is what this video was for. The fear I hear most consistently from patients over 70 is not about illness itself. It is about losing control. Losing the ability to make their own choices, manage their own days, remain in their own homes. That fear is real. It is justified by what they see happen to people around them. What I want you to understand, what I would have said to every patient I ever had, if I could say it again, is that one of the most practical, concrete things a person can do to protect their independence is to understand what is in their body every day. Not just by taking the pill, but by knowing what it does, knowing how the body processes it at this age, and maintaining an active and informed conversation with the person who prescribed it. Tonight, before you sleep, not a medical action, just a human one, look at your medication bottles. Just look at them. Read the names. Hold them in your hand. Ask yourself honestly when you last had a real conversation about each one. That awareness, all by itself, is the beginning of taking charge. And taking charge of your own medical care is one of the most powerful things you can do for the life you want to keep living. Let me close with the names, because they deserve to be said plainly. Cyclobenzaprine. Muscle relaxants like Flexeril produce double the blood concentration in a body over 70, impairing the brain chemistry that keeps you coordinated and clear, with a documented 22% elevated risk of injury, requiring emergency care in adults over 65. Fluoroquinolone antibiotics, Cipro and Levaquin, carry an FDA black box warning of tendon damage and a 47% elevated risk of peripheral nerve injury that develops weeks after the prescription ends, with the highest risk concentrated in adults over 60. Glyburide, a decades-old diabetes medication still widely prescribed, continues stimulating insulin release even as blood sugar falls dangerously low, making adults over 65 more than 3 times as likely to experience a serious hypoglycemic episode. SSRIs, antidepressants like Zoloft and Lexapro, carry a 5-fold elevated short-term risk of hospitalization for dangerous sodium depletion in older adults, a risk that multiplies dramatically when combined with a diuretic. Digoxin's therapeutic and toxic levels are separated by so narrow a margin that the natural kidney decline of normal aging can push the drug across that line, with a 1-year mortality rate of over 40% in patients who experience significant toxicity. And atypical antipsychotics, Seroquel, Zyprexa, Risperdal, carry an FDA black box warning of a 60 to 70% increased risk of death in elderly patients, and are prescribed off-label for sleep and behavioral management in millions of older adults every single year. Now, the 4 words I promised you at the very beginning of this video, here they are. At your next appointment, say this: I want a Beers review. BEERS. Your physician will know immediately what you are asking for. The Beers criteria is the American Geriatrics Society's formal, evidence-based, regularly updated list of medications that are potentially inappropriate for adults over 65. 4 words, 1 sentence. It is the most direct way to trigger a comprehensive medication review in the language your doctor already knows. Has a doctor ever changed one of your medications and you later found out it probably should have been changed sooner? Leave that in the comments. I read every one personally, every week. Next week, I am covering what happens to common blood pressure medications when kidney function declines in older adults, and a specific combination taken by millions of people that significantly increases stroke risk. One of the drugs involved is considered completely routine, and most patients taking it have no idea what happens when it is paired with a certain second medication. Press subscribe or tap subscribe just below this video to make sure YouTube sends it to you. It is completely free, and there is no cost whatsoever. What I will share in that video about the blood pressure combination may be the most important thing I cover all year. As always, please speak with your own physician before making any changes to your medications, especially if you are managing heart disease, diabetes, kidney disease, or taking multiple prescriptions at once. I am not your doctor. This video is educational information, not medical advice for your individual situation. Your body, your history, and your full medical picture require the guidance of someone who knows you specifically. What I have given you today is the knowledge to have that conversation well. I am Dr. Robert Miller. Thank you for spending this time on your health.